it's a good afternoon to COVID scientists and warriors. All together, we welcome you to the second learning webinar series of Global COVID Network, which was launched last week by Sambodhi Research and Communication Organization, the Indian Social Responsibility Network, New Delhi, and the University of Washington, Seattle. Today, we also have the senior officials of the two co-sponsor agencies, Mr. Sudhanshu Malhotra, who's the Vice President of Sambodhi, and Mr. Santosh Gupta, who is CEO of Indian Social Responsibility Network, which is a grassroots network of people working in the health sector in India. And they are connected, and both of them will be available on the question answer session at the time when we finish the speakers. So the second webinar that we are going to start now is on epidemic preparedness and mounting responses to COVID. A quick recap of the first webinar held last week. It had discussed something clearly about 4 stages of COVID pandemic. And after the fourth widespread epidemic outburst is over, whether the subsequent episodes or subsequent waves would happen or whether it goes into resolution. So we still needed to learn more about that. Dr. Dermot Mahe of WHO, he traced the first occurrence of COVID to China, where widespread outbreak had occurred. And soon after, there was South Korea, Singapore, Italy, United States, and many European countries. They saw widespread outbreaks. So as we meet today on the 5th of May, 2020, there are already 3.5 million infected people across the globe, and about 260,000 people have died, and numbers are counting. And Dr. Dermot actually looked at Africa and Southeast Asia, and he thought they will benefit with increased testing to determine the real size of the epidemic in their countries. The second speaker was Professor Pierre Yassa, who's Dean of Bukavu University Medical School in DR Congo, and he stressed Africa's need for global funding to expand on the testing facilities and quick containment, just as they had done it before for the Ebola epidemic in 2014. Dr. Judith Wasserheit, chair of the global health at the University of Washington, she emphasized on flattening the pandemic curve using the infectious disease formula, basically the RO, which is the speed of transmission of the infection, equal to beta CD, C for number of contacts and D for duration of infection. And the prime aim is to reduce speed of transmission to less than 1 with all the containment strategies and more that we would learn today and subsequently in the total 6 webinars. We are familiar with this infectious disease formula, RO equal to beta CD, but this is one of the simplistic formula that was brought up in 1980s and has subsequently survived several epidemics. But with this COVID, we are now finding more stronger variables which are not included in beta CD here in this infectious disease formula. And so today we will have the second speaker address some of those strong variables, such as the economic integration and travel integration between geographies in terms of transmission speed of COVID. All the speakers in the first webinar had emphasized on global partnership to share lessons and technical information. Today, we are pleased to welcome our esteemed colleague, Dr. Xiao-Nong Zhou. He is Professor Director of National Institute of Parasitic Diseases at the Centers for Disease Control and Prevention of China, and his two colleagues, Dr. Ning Xiao and Dr. Shan Xiao, also to present the Chinese experience and the preparedness of COVID epidemic. So it's over to you, Dr. Zhao.
Yes. Thank you so much. Yeah. Thank you so much, Dr. Hira. And thank you so much for your invitation to participate in this webinar. And this network already been done very good webinar. Then this is the second one. So we are happy to be participating in this one. And today I would like to present the lessons learned from the battle against the COVID-19 in China. Since some of my colleagues also has been working in the front line of the epicenter. So I would like to invite another two of my colleagues to participate in this presentation. So my presentation are going to be three subjects. One is the general scenario, and the second one, what kind of lesson we learn. And third one, we did a small study on the transmission patterns and recovery from the COVID-19 in China. So I will present the first part, and my two colleagues will present another two parts. So goes to the first part, general scenario of the fighting against the COVID-19 in China. So all of you can see these figures. You can see the blue color is the local cases we reported since the end of the last year. And you will see the curve, and really it's fit well to the some infectious disease curve. And the red color is or you can say the second wave, which are imported cases after the start from beginning of the February. So up to the 28th of April, a total of 8,200 and 858 reported cases was reported, and more than 7,700 individuals was recovered from the treatment, and about 4,633 people was died of the COVID-19. So when you calculate the accrual case fertility rate, that was 5.6%. And you can see the curve reduced very quickly because of our strong intervention or containment countermeasure really effectively. So that's why the number of the cases is this new reported cases reduced every day. But the imported cases started from the beginning of February, and then later is here from the later of March. Most of cases are imported cases in red color, so you can see here. But in recently, we also find the asymptomatic infections. So totally about how many? So now we can see what's kind of our containment measures we did. So this combine those contain strategy, including the social mobilization and the personal protective measures, with hand hygiene and masking wearing. Mask wearing, we thought this is a very, very important, particularly when people gathering together. And if you wear the mask, it's really help you for you protect yourself. Also, you protect your, if you are patient, you will spread to the others. So, and avoiding the gathering and keep the social distancing also very, very important. So all the, because in the beginning of the outbreaks, it is in the Chinese New Year festival. So all the activities about the Chinese New Year activities stop. Even the hotel and even the restaurant, because everybody want to involve this battle and keep the social distance. And but for our medical doctor and our public health workers, we are working on the mainly 4 early, and one is early detection. Second one is early diagnosis. Third one is early isolation for the quarantine, and the fourth one is early treatment. And also for the epicenter in Wuhan, they locked down the city, so the movement restriction was happened almost for 3 months in the epicenter. But for the other cities around the country, only maybe around the 2 months. And particularly for the during the outbreaks, for the hospital, we focus a lot on the prevention and control of the nosocomial infection. This in the hospital, we have to do a lot of work on this. And also environmental measures, we are routine cleaning, and so some insecticides also be used in the surrounding environment. So these are containment measures. And if we would like to summarize these experiences we already learned from the battle against the COVID-19, I summarize here, and my colleague Dr. Xiao-Nong will give the more detail how many experiences or lessons we already learned. So basically, for the country, we divided into 4 lines. So first line, which means the front line of the battle, was the Wuhan epicenter, and surrounding the Wuhan, they call the Hubei province. Hubei province, they consist of more than 8 cities. And the second lines that was in Beijing. And Beijing, because in the later stage, there are a lot of import cases due to the international flights. And the third line is the regions surrounding the Hubei, connect the Hubei province, those where they had more cases than other provinces. Then for other provinces, we call the fourth line, nationwide. And as I mentioned already, that so 4 early, so which is early detection, early reporting, and early isolation, and early treatment. Here, probably I majorly want to focus on the early isolation. In the Wuhan area as the epicenter of the outbreak, when so many people get the syndrome, they would like to go to the hospital. In the beginning, the hospital is full of the people. So, but the government quickly made the decision to building the 2 big hospitals. Each hospital is more than 1,000 beds during the 10 days. So this can be help for those patients to be settled down in the hospital. Second one is we also building the more than 10 quarantine hospital. Those quarantine hospital mainly to those has been detected as positive in the COVID-19. and those people has to be coming into the quarantine hospital, because if they still stay at home, the home cross transmission still happen. So it's difficult to stop the transmission. So once the quarantine hospital was built, actually in the schedule, in the school or those bigger area, so more than 10 quarantine hospital was built. So everybody, whenever you had a syndrome or you tested in PCR are positive person, they will be there. And then the 3C, particularly the community engagement, community health education, and communities involved in the hygiene and disinfection activity. So this is also very important. And in the whole country, and everybody involved in the help the Wuhan hospital and for the rescue of the patient, and also support to move some public goods like PPE and to supply to the Wuhan. So which need coordination, cooperation, and communication, and to put the logistical support to the epicenter. So actually a totally 40,000 health workers, including the medical doctor, nurse, and public health work from each provinces to support the Wuhan and Hubei province. So all those people are really contributed and as a hero to save a lot of life there. So this is my first part presentation. 夏桑，需要你进来了吗？ So now I would like
okay. Thank you very much. I think thank you. It's my honor to join these meetings. It's a very important meetings. So first, as I mentioned by Dr. Zhou, there's several key experience we had in China. So let's move to some parts. I will give more details. First is lesson one is so all the infectious diseases control, we have at least, basically the principle is the same: early detection, early isolation, early report, and early treat. So first, we want to know some of the definition of the case. In China, we classed the case into the suspect case and confirmed cases. So of course, for the asymptomatic individuals and the contact is some of them is the potential infectious resource, so we must take care. First, I want to mention the case definitions in China. Suspected cases have to meet the two criteria. One is the epidemiologic histories. The second is the clinic symptom. So it's very important, but it's not confirmed because without the evidence of pathogen, we cannot make these confirmed cases. So the move to the second part is suspect cases plus the pathogen confirmed. We use the RT-PCR. If positive, we confirm. Or the viral gene sequence is highly homologous to know the virus is also confirmed. And the third is newly, if used the criteria for the IgM, specific, and IgG, detectable, or the specific IgG is reach the titles of at least 4-fold increasing during the convalescence compared with the acute phases. So for the second is not really reporting, but it's a very important issue is contact. How to trace and manage is very important. So for this contact searchings, multi-sector cooperation is very important, like public health securities, authorities, and the many a department should be involved to searching, to find the contacts. This contact is must within the several days. They contact the case, confirmed cases, or the suspect cases. How to find, how to tracing. So CDC, as you know, in China, CDC has played a very important role to respond for the investigation to find the close contact. It looks like the detectives, so should be carefully to find any clue to tracking, to tracing the contact. And the contacts under the quarantine, usually at home or at a designated place like a hotel for at least 14 days for the last contact with the case or the symptomatic individuals. So temperature and the symptom should be monitored twice a day. Usually outdoor activities not allowed. So this slide should mention that we must pay much attention to prevention and control of the key settings and populations. As you know, healthcare facilities should be strictly implemented nosocomial infections, because if any hospital inside infection should make a lot of troubles. So it's very important. And the second is it's essentials to implement effective disinfection of the place. The places where the COVID-19 patient or symptomatic infected stay there. So must be disinfections. And also it's essential to ensure the effective protection of the professional work in the epidemiologic investigations, isolate works, and medical observation site, environmental screening and disinfection, and specimen collection, and laboratory work, and transportation, transporting cases and infected persons or the suspected person. And as you know, the special care and management of the special population must be highly pay attention. In many countries, such cases happened in the prisoners' psychological side and the prison institution. And earlier treatment is, of course, is very important to reduce the risk of the death. Any case must take the good rest and support therapy like nutrition and oxygen support, supplies, and antiviral therapies, and also ECMO, CRT, and tocilizumab, convalescence plasma, and the traditional Chinese medicine, all be tried and be used. It's very effective in China, especially in Wuhan. A lot of cases have been saved. And of course, in the Wuhan, it's very special, it's locked down. But when everything is under control, so we need to know the transition stage. So how to make the risk assessment? It must be based on the risk of the strategy and the measures. It's adapt the local settings. At this stage, it's very key, still follows or adhere to the 4 earlier measures, and then like importation and control, the cross-border, and also the province, especially in the key and the big cities, and the prevention and of the local spreadings. It must be carefully watched, like the epidemic investigation, close contact tracing, and management must be conducted. And for fine-tune approach to balance the response and economic development is key issues. As you know, now the many countries, one hand is for the control of the COVID-19, but on the other hand, is released and for the resume of all the manufacturers. It's very important to make the good balance. And the last is utilize the high tech, such as the big data and the AI, artificial intelligence technique, to carry out targeted measure, like tracing of the travel histories, close contact, and transmission chains. So it keeps every crew to find any new case or any evidence to show the contact must be under quarantines. And also the timely risk-based precise strategy is very important. In China, we divided the whole areas into the 3 levels. One is the low risk levels. In these areas, strict prevent importation is the key issues, because in these areas, almost no confirmed cases, or no new confirmed cases was within the 14 consecutive days. The next is the middle risk areas. The strategy for this area is to prevent importation and block the local transmissions. As you know, in this areas, not so much, not highly, the cases are accumulated. So in these areas, we must be carefully block local transmissions and the prevention of the imported cases. And the last is the highly risk areas. In these areas, like Wuhan, first issue is to block the local transmissions and prevent exportation of any cases. So any measures must strictly conduct. So risk, but anyway, risk level is dynamic and adjustable. So when the resumes of the manufacturers, we must be carefully. As you know, it's not easy for the high risk go and return. So we invented the health code and the travel card. For the health code, we have used our mobile phone or the paper card to show the color. If the red colors means this person come from the highly risk areas. So must be get the more monitoring and the quarantine, the 14 days. If the yellow colors is from the middle levels of the risk areas, usually they be under quarantine for 7 days. If the yellow colors, if the green colors, it means it's come from the low risk areas, so it's keep it safe. But how to ensure the transportation risk infection? For example, if they travel to the other areas by the train, by airplane, or by the bus, we must be carefully to making sure that no reinfection. So we organize migrant workers to return to the work site in the very ordinary manners through the cross regions, like point-to-point labor corporations. So different provinces have to make the close collaboration to make sure these workers keep safe, no any infection risk. And then prevention and control of the guideline must be prepared in any enterprises. So protocol for health monitoring and reporting and management at the workplace and the living area, all the guideline must be prepared and to training to everybody to follow this protocol and follow the guideline to ensure the no potential reinfection occurred in the workplace. Next slide, please. This shows the control strategy for the imported cases. As you know, in China now is almost no new cases, but we face the high challenges from the imported cases outside. So whole chains management from the border, from the port to the community to home, each chain must be carefully, strictly controlled. And like the entering, screening, 14 days history and health status reporting. So everybody, when they enter China, they must report within 14 days what they are traveling and what's the health status. And also, of course, temperatures must be monitored carefully. And the 4 categories of the person, this must be strictly under control to not allow any potential infections to spreading to the other side. And medical examination for suspected symptom and this is must be by the inspection through the port and the transfers these cases to the usually the suspect cases the transfer to the designated hospital and the close contact to the designated hotel for the quarantine currently. And the quarantine policy for travelers, usually 2 weeks quarantine in the designated hotel, depending on the risk evaluation and the local policy. As you know, in some of the areas, 7 days is enough, but some of the areas have its home policies, 14 days. So we are not we are equals, regardless of the travelers come from the domestic. They are also for the foreigners. We are all the same policies. So it's some certain issues of lessons. It's my experience when I was in Henan, Sichuan, and some areas. I find some of the very good manners to ensure the prevention of the spreadings. It's better to centralize close contact for isolations. You know, in the at the early stage, most of the close contact be in the home, in the full isolation, but we find the cluster infection in the whole family. So we are concentrated to the one isolated for isolation and transfer the severe cases to the provincial hospital or above for the good medical care, treat to save the life. As you know, in the provincial levels or the national levels have the very good condition for the medicine condition cares. And the preparedness for the preventing the outbreak of transmission inside the manufacturer must have very detailed preventive and emergency protocols. So each step must be strictly followed. And the triage site and outpatient specific for the patient's medical consultation must be set, which means separated from the other normal patient. Otherwise, it's a cross-infections occurred in some areas. And good epidemiological surveys is very important. So any investigators looks like detective find any crucial. So this is summary for my parts. The very key issues for the 8 items. One is this science-driven response, and the core traditional public health measures should be, and the critical bottoms positioning and statement, and the community mobilization and response. This key is very important. We have the very good communities mobilization. So the community keeps their safe very strictly. So it's keep the outside importation. That's our very good styles. And the transparent public health communication, public communication, and the risk communication is very, very key to let the public know the potential risk. And international cooperation currently shows the most significant now. And the government leadership, coordination and cooperation also it's very important. As you know, now is China have the joint mechanism by the state council to show a lot of the benefit to organize to the any prevention and control. And the last is the logistic support. Is to support all the actions. So it's very important. Thank you. Thank you very much.
Okay, thank you, Dr. Xiao. And Dr. Xiao has been Italy from Chinese medical team to help the Italy as well. So now next, I would like to invite Xia-Sang to present the third part.
Okay. Okay, everyone. Yeah. I'm really honored to have such an opportunity to introduce some modeling and prediction works. As you know, since the city lockdowns in Wuhan, our modeling teams start to work together to make some predictions for the future epidemic dynamics, and also we try to evaluate the possible impact and about the society's resumption, such as the school closure or go back to the workplaces. Now here, I would like to introduce some of our preliminary results, and these results and the methods and all of the details you can to follow this reference on the bottom of this screen. In this study, in our early study, we mainly focus on three key questions. The first, we want to know what's the risk and trends of disease transmissions in different regions, because you know in China, the cities, they all have their different characteristics. The second question, we focused on how to evaluate the effectiveness of the intervention strategies. The third one is we want to know what will be happens when the school resumptions go back, or the peoples go back to their workplaces, whether or not there will be the second outbreaks, and also about the economic loss if this city lockdown continues. Okay, next slide. Okay. In order to do so, we have adopted age-specific disease modeling works. Here you can see we have divided the populations into 7 age groups. For each age groups, they have some special social characters, such as they are whether or not they are the school students, or whether or not they are working or stay at home or something. So. And also we have integrated 4 social settings. We believe that the disease transmission may occur in the social settings, such as their household, people are close contacts with each other in the household, and also the schools, including the colleges and universities. It's also a lot of people are gathered together. And it's a physical workplace and a public communities on public places. So in our model, we have, you can see age and social siting. Based on this model siting, we have utilized the demographical census data. By applying some computational methods, we can estimate the contact frequencies between different age groups, and also the contact frequencies among these age groups in different social settings. You can see some detailed mathematical descriptions in our paper. Okay, based on this methods, we have collected 6 cities, 6 typical cities in China from the north to the south. These cities, we have their census data, and we calculated the contact frequencies among different age population groups. Then we utilized some parameters from the early studies of the COVID-19, such as their R0 value, their transmission rates, and so on and so forth. We can produce some predictions for the disease transmission dynamics. Okay, so in this slide, you can see if without any interventions, for example, if we have assumed the R naught to be the 2.5, without any interventions, the disease curve is a source into the sky. If we have utilized the very strict social distancing methods, we can lower the curves for the newly reported cases. And also, we have set up some intervention scenarios. Professor Zhou, next slide, please. We have set up some different scenarios. These scenarios is try to describe the disease intervention measures, such as the society's close-up, for how long, for 2 weeks, for a month, for 2 months, and also the resumptions for different scenarios, such as the school closure stopped first, then the workplace stopped first, and we want to see what will be happened for the disease dynamics. Okay, so in this picture, you can see we have set up many scenarios, and with our models, we can simulate whether or not if we resume the school closure or the city's lockdown, whether or not there will be the second outbreaks, and what's the peak, what's the intensities of this possible outbreak. And by doing so, we have compiled 6 cities. Also, Wuhan is some special, very specific cities. For another 5 cities, it's the local imported cases cities, such as Hangzhou, Suzhou, and other cities. We can give some quantitative descriptions about the effectiveness of their. So due to the time limitation, I will not give some detailed description. You can see our papers published, and based on the last year's economic development data, we also try to give predictions for the possible economic loss in each cities, and we can see if this intervention measures last for a month or 2 months, what kind of economic loss will be happens. Okay. So here is a very quick summation and some highlights about our results. Here we have 4 key implications for this study. The first implication is the main proper social distance measures is still essential, even when the school and business activities are resumed. Second, based on our model, we have identified the middle-aged peoples as the most important target for social distancing, because they are engaged in the schools, are engaged in their workplaces. They might be the hotspots for disease transmissions in different age group. So this middle-aged population should continue this social distancing methods. The third one is even within a country, such as in China, the social distancing measures should be adjusted dynamically to different cities, especially when these cities has different population structures. I mean, the age or different type of working places and so on and so forth. The fourth one implication is we believe that this method is general method, which can also be used in China in different cities or locations, and also in different stage of the disease transmission. We also highly encourage this method can be used in different countries, such as right now the countries are also in different stages. So here is a very quick and a brief introduction about our modeling and prediction works. Thank you so much.
Great. It was a very good presentation, Dr. Zhou. Do you want to add something to it, or we have actually I didn't want to stop at any point, because this is the first-hand information with people who have been the frontline COVID warriors in China. And there are lots of participants today who are policymakers and implementers from different states and countries of Africa, Asia. So I think what we could do is allow 2 questions so that if there are burning questions, one, of course, I have a burning question, and I will come up with that. Is the question is, considering Wuhan as an epicenter, the epidemic, once it got controlled, and then we heard some publications from China which talked about 180 people getting test positive again on PCR, and was considered possibly as a second wave. And later we heard that it was not actually infection, but it was herd immunity in terms of IgMs. So can you clarify that, whether there was a second wave in Wuhan after the epidemic got completely controlled? And if second wave was there, what would be the implication?
Okay, Xiao-Nong, can you respond to this one?
Okay, thank you. Thank you for the questions. I think it's very important for when the lockdown of the Wuhan. So, you know, Wuhan is quite a very big cities. So as you know, recently, we already the massive serologic surveys are be done. But up to now, the data is not completely be analyzed. But I think the population's infection rate is not so high as expected. So for the herd, you mentioned the herd immunity, that's right?
Yes, I mean, whether it was a second wave was a reinfection, or was everybody thought that it was probably the antibodies of IgG that appeared and was being wrongly quoted. So I'm asking you, what was the real situation in the second wave?
Second is your second wave is of course is high. The risk is the potentials, but as you know, now even now is no new cases come out.
Okay.
So all the Chinese the state council sent a lot of the supervisors to the Wuhan cities to still give the close monitoring to each. Measures must be strictly continuous. So we think at the moment, we have the confidence to such cases maybe not happened, but
Okay.
we still have to pay attention to that.
Thank you. Got it. Thank you so much. Is there any burning question? I see 2 questions being put in. But I think Santoshi or anyone wants to come up and say, anyone wants to ask a question? Otherwise,
hello, Dr. Hira.
Yeah, please.
So we have some media personnel also in the webinar. So one of my friend from the Dainik Bhaskar, Sandeep, is also in here, is the participant side. So basically, I would like to ask one question. Like, first of all, thank you, Dr. Noggs, your wonderful presentation. You are your slides and your information, certainly that they have useful for us. So, and I would like to ask one question, like out of all these success reasons that you told, can you please share one major success moment that you took China out of COVID-19?
Okay, please respond. Dr. Zhou or Xiao-Nong?
Did you hear the question about the measles?
No, the question was that if you have to say one major strategy,
yeah,
that made the difference. if you want to say one or two, because Santosh Gupta is one of the policy influencers in India. Yeah.
I think this question is very important because in China is so big. One province is the total number of the population as like one country in Europe. So different policy in different places that should be done, because the epicenter is like Wuhan and Hubei province. The policy is one, and in the other provinces, as we mentioned, the first line, second line, and third line, and fourth line. Each line, they have their own policy. For example, we only had the lockdown for the Wuhan city, but all other city not lockdown. Of course, we encourage people and give the education, health education, that people it is better to be working at the home, working at the home office. Then they can help for the stop the transmission. So during the several days, people working mainly at the home, and different city also differently, and even the countryside they also use a different policy. So and Dr. Xiao-Nong also mentioned different stage, even in a different stage of the epidemic, they also have different policy to make. So they, particularly during the peak of the epidemic, really they change the policy maybe every 2 days. So because sometimes they move strictly, and sometimes slowly down and slowly open. And you can see now this month, since the beginning of this month, all the China now they almost can traveling from one city to another city, but not for last month. And the last month maybe only few provinces like this can be traveling free from one city to another city, but most of city not like this. But in the beginning of May, you can traveling everywhere. But everybody they have the green card. This green card is a digital card in your mobile phone. So whenever you have the green card, you can travel. But if you are positive, your card will become yellow or red. So this digital really help. Digital technology really help for this antivirus activity. Thank you.
Excellent, excellent. I think I'll just try and catch up one or two questions. One of the face of Indian television is Dr. Swati Maheshwari, who keeps the communities informed about the COVID epidemic. And she's asking a question that wants to clarify that anybody who has cleared COVID through at a certain stage, can he or she get reinfected? And if so, within how much time? So basically, again, saying herd immunity would be protective for how long?
As my knowledge, we haven't seen any cases who had a reinfection after the first infection.
Okay.
So up to now, the answer is no.
Wonderful, yet. Wonderful. I think we got that answer. And Professor Yasa has left a question. He's one of our Dean of Medical School in Congo, and the slides will be available and will be mailed to all the participants by the Secretariat. So if there are some questions, we'll again catch up. So thank you so much, Dr. Zhou. You have been so helpful, and the Secretariat and the co-sponsors are very, very grateful to you for your time and pretty elaborate presentation. We will now then move on to the second presenter. And the second presenter is a data analyst. He is from the Apex Elite Institute in India called the Indian Institute of Technology. And his name is Mr. Jay Mrug. he's quite a prominent face in terms of using artificial intelligence for using data analytics, as well as now using the data intelligence for COVID. And I will leave it to him to maybe introduce himself a little more. But just to say that when we were bringing him in with so many different models and mathematical models flying around and between the optimistic and the pessimistic part of the spectrum, I always thought that this COVID modeling was just like COVID horoscope. So it is up to us to believe it or not, to understand what a horoscope keeps saying. So, okay, Mr. Jay Murg, would you come in? And Dr. Zhou, you can be there, and towards the end we have question answer session, so maybe there might be some more questions which we have not been able to answer. So if you can be there and spend more time with us, is that okay?
Yes, it is fine. We are still staying here. Yeah, no problem.
Wonderful. We are very grateful. So, Dr. Murg, please.
Thank you. Good evening, gentlemen in China, and good afternoon in Africa. Are people able to hear me? Okay, thank you. Thank you. Thank you. I'll quickly share my screen, and yeah, so that's the screen. We'll make it full screen right now. Yeah. So basically, our company is, was incubated by IIT Bombay, a premier institute here in India, and our objective was to build vertical agnostic models in artificial intelligence, and models that could actually be scaled up, could be taken to the level of a software product. And I'm actually grateful to Dr. Hira for having thought that I was worthy enough to present on this forum, because we sort of focus on how data can be made amenable to modeling, and what it is that you should look into data to meet your goals, the decisions that you're trying to take. And somehow Dr. Hira and Santoshji thought that I was worthy enough to make a small presentation, so I'm grateful to them. So here is what the current situation is like. There is a lot of data available currently. Either a processed data from Johns Hopkins University, or advanced models from the Singapore University, or even a lot of I'm very happy to say a lot of the people working in the social sector have crowdfunded together to put up portals to give data about what's going on. There are almost hourly updates on many of the portals like Worldometers or COVID-19 org.india. There's a lot of hourly updates available. Now, we do not come from the medical science fraternity, but from the sheer perspective of analysis for people who are more or less, data enthusiasts. What would you actually look at? So one thing that obviously first comes to your mind is the deaths per test. Deaths, actually, what is the number of deaths? Now, if you're actually trying to even work out in a refined way that not every country or not every state has been equally tested, then you would like to look at a metric which is death per test, which is the mortality metric. Now, that's the chart we have on the left-hand side. And if you look at it, it's got a fair sprinkling of countries. That's which are a fair mix. They're not easy to classify or do a pattern classification on them. So you have Algeria on the top with 6.76 in the deaths per unit tests conducted. This is into 100, by the way. I just want to give the disclaimer. It's not that 6 are dying for every test. It's into 100. This number is a percentage number. And you have Belgium at the 4th place. The most common herd of European countries, which are in news for a large number of coronavirus infection cases, and a large stress on their medical systems. UK and France, they come at the 7th and the 8th position. Again, you have Brazil down at the 14th, 15th, you have Ecuador. Now, the key is, how do you actually go about saying that you would like to have a more structured way of looking at your data? So one way to look at it is, say, cases per million. Yeah. If you rank, now this is the data that we had as of the 3rd of May in the evening. Okay. If you look at the cases per million, you have San Marino at the top. And of course, we've just taken the first 15 or 16 positions to get a larger perspective of data. You have USA at the 14th position, Italy 15th, and Switzerland at the 16th position. Now, this gives some idea. Cases per million is a good metric which gives some idea about the whys of the spread, not just the hows, but the whys of the spread, like sort of. So if you look at San Marino, it's like a small enclave, almost surrounded on all sides by Italy. It's a very popular tourist destination. You go down, Spain is again popular for tourism. From Belgium onwards to Isle of Man, right until Switzerland, from the 10th to the 16th position, you have a great deal of economic engagement with the world, either in terms of the financial engagement or corporate structures that have companies over there. So you get into more of a sense of understanding that the infection, the spread of the infection, if we look with an appropriate metric like cases per million, was actually driven by this economic and travel integration. Okay. And we just quickly go down to the next slide. So now the key is, how do you actually ascertain which are the factors that are impacting the spread? I mean, if we were to say that, give us a sort of statistical multiple that, if I take factor A and I collect some data for factor A, well, that makes one part of the story. If I collect some data on factor B, which makes another part of the story, then what we say in simple statistical language is, can I multiply probability of infection due to factor A and probability of infection due to factor B, and then try and get a score, or can I get a rank which will say how infected a particular region or state will be. So at our end, we actually tried to identify about 4 issues which we felt were the key issues that were sort of impacting the spread. So one was economic and travel integration, international economic and travel integration of that particular nation. The other was also internal integration. In India, we found that even internal economic integration was to a great extent impacting the spread. The population densities, especially in urban areas. And fourth, what is the social infrastructure available to implement social distancing? Is the urban structure there, or the societal structure there capable of handling social distancing? So on these 4 factors, we tried to get some initial sense of an estimate. We first looked at Italy, and there's a small box there where we have listed the top 10 global importers as per 2018 data. So currently the global imports are actually taken as a surrogate metric to help identify what is the extent of economic integration of those nations. And they're spread across continents, and you find that 7 of these are in the top 20 countries infected by the virus. So the extent of economic integration actually made more travel between the two places. There was more people-to-people engagement, and that people-to-people engagement, sort of opened the doors for more communication. So let's take the case of Italy, which became the first epicenter in Europe. It had very close ties with China. To the extent that there were direct flights from northern Italy to Wuhan. The people-to-people connect and connections were very strong. Almost over a lakh citizens from China moved to Italy, work in their factories. There was Chinese ownership of Italian firms. So economic integration was, in a way, a trigger that helped the faster spread. And countries, as we go in the previous slide, at the bottom over here, each one of these has a fair degree of economic integration with some of the big superpowers in the continent. So each of the countries, again, becomes a conduit for the spread. We come to India. We looked at the cases, confirmed cases across all the different states. And here again, we tried to develop a surrogate metric. The metric was, what is the geographic distance? So Mumbai is the financial capital of the country. What was the geographic distance from Mumbai to other states, and how do their confirmed cases look like? So Delhi is, an economic epicenter in itself. Tamil Nadu is also an economic epicenter in itself. Both of them had participants in certain events that led to spreads. But by and large, if you go down the geographic distance away from the economic epicenter, you're actually seeing those many lower and lower number of cases. So that's one thing, that the distance is indeed a surrogate indicator, as to how much the spread tends to happen. We observed similar trends in New York as well, in the United States, with New York being the financial capital. We also looked at population density. Yeah. So here we ranked the top 10 states by population density in India. And the states of Bihar and Bengal, the population density is high, but their economic integration with larger cities like Delhi and Mumbai is not as high as of other neighboring states like Rajasthan and Gujarat. So though their population densities are higher, it's not as much a case that they have actually recorded that much of the high number of infections. So if there is absence of other incidental factors, then the likelihood of infection is more. But a combination of being closer to an economic epicenter as well as a high population density can, become a reason for a high number of infections. So Chandigarh here, its density is pretty high, actually, quite close to the National Capital Territory of Delhi, but it has, and it is closer there, and it does have a large number of cases. Now, we actually look at the social infrastructure that's available to implement, the social distancing. Now, how does it happen? There's very interesting data that we have about the situation in the slums. That is, a lot of the lower income group residences in India. There is a classification about the number of people whose household structures are almost about just one room. In Gujarat, it's about 69% of those people staying in informal accommodations, which is slums. 69% is one room. In Maharashtra, it's not close behind, is not far behind. It's about 67%. In Delhi, it's 61%. and progressively in other states it's lower. And so even if the housing is informal, it's unregistered, it's undocumented housing, yet in other states they have more rooms available. Right? So if you see for houses with 2 to 3 rooms and undocumented houses in Punjab and Haryana are looking almost at 50% of the population. Undocumented housing, but even say 4 rooms, it's still larger. Rajasthan onwards, about 14 to 15% of the undocumented housing space. Now this social infrastructure of sorts, gives an idea of how much social distancing is possible within those states. Now, this is like turning out to a very surefire indicator. These are almost today the top 4 that you see here: Gujarat, Maharashtra, Delhi, and Tamil Nadu. If you just swap their order, these are almost the most infected states today in India. So the availability of social infrastructure and whatever local self-government interventions that could be possible to at least ramp up the social infrastructure during the pandemic really serve as an ability of a measure of their ability to help handle the situation. This list is almost mirroring the sort of list of infected states in descending order in India. So social infrastructure with surrogate indicators like number of rooms available in the house, or even the per square mile density in a slum really make a difference. Like, so for example, in Mumbai, we have Dharavi, Asia's largest slum. And on 3rd of May, the tally was about 590. This tally of Dharavi is actually more than the tally of the state of Haryana. It's like, that's the sort of magnitude that gets impacted with the availability of social infrastructure. We look at 2 very interesting cases. Now, this is, given the fact that a lot of our COVID and Corona warriors are battling the situations on the ground, and we have data coming in every day. What do you look in the data, to say that the country, the cases are flattening, but what should decide, whether to what extent is the recovery happening place? What should be the analytic metric to assess the extent of the recovery? So if you look at this percentage size of this funnel, so I'm calling this the funnel. Yeah, so we've taken this from the worldometers.info, and they have created this mapping between death rate and recovery rate. The orange line is the death rate, and the green line is the recovery rate. On the right hand side, you have the picture for India, and if you look at it, the death rate, the orange line, like somewhere around the middle of March, was threatening to get close to the green line till the 26th March, almost to the first week of April. But after that, the gap widened, the funnel grew bigger. The growing width of this funnel indicates that the measures that the self-governments and the national governments have taken are working. And though the curve is flattening slowly, there is hope of saving lives and containing the magnitude of the impact of the virus. So the funnel keeps widening. The green line tends to grow more and more away from the orange line. Yeah. Now, on the left-hand side, we have the same picture for Italy, and this is the reason why Italy was a case of worry for a long time, almost for a month and a quarter. You can look at Italy's graph starting on the 19th of February and going right until the 3rd of April. Only after the 3rd of April did the funnel gap widen. It started widening substantially. In fact, in the beginning in Italy, the orange line, the death rate, was actually substantially more than the recovery rate. It was indeed a picture of fear. And eventually the funnel started widening. So this is also an important metric that, if the funnels widen, because most governments today are also concerned about the complete shutdown of the economic activity. If the funnel tends to widen, then, the governments can go for some amount of opening up. because once the curve starts flattening, the second metric or parameter you want to look at, like, am I sure or am I confident I can start opening up? So once the funnel, the gap between the green and the orange keeps widening, maybe governments can get more confidence that they can start opening up. And that also explains, Italy's opening up of a fair amount of the country. It is this widening funnel which gives the confidence to the government. Now, I'm just trying to summarize a few methods, that we can actually make research on data stronger about. One is the pure play regression, which is similar to the Singapore University model. Yeah, it's based on regressions and it sort of tends to give a forecast. But if you want to go further, you are actually looking for a more micro strategy. You want to know what are the different factors, how they're going to impact. You could perhaps go for AHPs, which are analytic hierarchy procedures. They give a deep relational expertise between different parameters. Like, so given the sort of say number of markets here in this place and the number of hospitals also available, what is the correlation coefficient I should look if I'm going to say the infection is going to spread, right? Or the infection can be contained given the fact that a certain region has both markets and hospitals, right? So those sort of detailed correlations, you can actually get to the AHPs, which are the analytic hierarchy procedures. You can also use learning networks. Yeah, so these are neural networks. They are an old science. They're not a new science, but in the current scenario, the availability of data has made neural networks very useful. And you can actually even use neural networks to simulate how the system responds to different data inputs. So you can actually pick data from the past, like say a certain containment in movement. In some places, people were simply not allowed to leave their house, vis-a-vis in some places a partial lockdown uplift, right? You can put in the data and a network can actually learn on its own and tell you what the future responses can be like. And neural networks can be perfected to a great degree. They're extremely popular. You can even look for, in your neural network, you can even look for early warning signals. Like early warning signal is a metric which tells you, okay, if these things are going to happen, here is the next outbreak. It's going to happen, right? So networks can even learn to give signals in advance. You can even optimize your response. You can go for response optimization, where machine learning can actually learn on its own. A computer can learn on its own how to classify patient criticality, how to re-optimize the allocation of resources. Machines can learn that on their own, and we don't implement them straight away, but they can be a very, very great help to the medical fraternity, as well as the local health officials to take certain critical decisions. So yeah, that's about it from our side. This was a pure data analytics perspective on the COVID outbreak.
Well, great, Jai. It's a very good presentation with real new variables added to the spread of the epidemics using the RO model, the usual the module that you use, RO equal to beta CD. So I think what we could do now, and the Secretariat please can guide me, do we have more than 3 minutes or do we have to shut down in 3 minutes? Camila?
No, we don't have to shut down. We can continue for a little longer.
Okay. So I guess what we could do then is, both the presentations have been so powerful. We could open up questions for both the presentations, because Dr. Zhou has been so kind to still be online, and his team is also around. So we can have participants ask questions and come in one by one. Maybe we can allow 3 or 4 questions, very brief, and please come along and ask questions so for anything that is you think are the burning questions. So anyone, because I have quite a number
I
of.
saw my colleague. He
I raise my hand.
Dr. Xiao, yeah.
Hi. Thank you, Chair. Thank you, Mr. Jan Maruk. Thank you for your interesting presentations. I have the very brief questions.
Yeah.
As you know, I heard some medium said in the northern Italy, it's the highest mortality and the mobility area.
Yeah.
So one community has the 20,000 Chinese, but these communities, no any cases, no any infected.
Yeah.
But in the outside the other Italians, there are a lot of the people get infections.
Yeah.
So I want to get your comment. What reason? It's a little bit different from your modeling. So could you please give us some explanation? Thank you very much.
Yes. See, it is also driven by the number of subsidiaries and factories and the manufacturing ecosystem that is around the regions of northern Italy. So when there is a larger economic participation from those regions as well, so as we said, it is a compounding effect of 4 factors, not just one factor. So in this case, the second factor, which is the economic integration of theirs with other epicenters in Italy, which takes over.
And essentially, you are saying that it's probably not related to one nationality, but there would be a lot of other immigrants and a lot of more people traveling.
Yes.
These are international ports.
Yes.
So yes. Okay. So that probably clarifies it now a little bit.
Yeah. Thank you.
Any questions? So while other questions are emerging, let me ask you a question, Jay.
Yeah.
What are you suggesting with this larger circle that you showed?
Yeah.
In terms of economic integration with countries or with regions within a country where COVID prevalence is high?
Yeah.
What are you suggesting that while this epidemic is on, and COVID is not going to be there forever, this is what I think we are clear with Dr. Zhou's talk. So while the COVID epidemic is there for some time, are you suggesting that within nations or within a large country, but in regions where there is more of COVID cases occurrence, you suggesting that the economic integration, which probably involves lots of subsidiaries and movements between people with the regions with low prevalence versus the high prevalence, you're saying losing that economic integration? Are you suggesting that? Because
I get your point. Actually, it's an opportunity to replicate more of those manufacturing enterprises in the other parts of the country that are not economically integrated. So for example, even 3D manufacturing, it's a technology by which you can just specify a certain diagram of a part or a machine component and a machine will manufacture it. So that would be the key to even within the high density epicenters to reduce the contact. So either way, whether those are not as economically integrated or more economically integrated, the reduction of the contact through technology, even 3D manufacturing, which is like a communication over an internet, is the key. I think that would hold the key.
So in other words, you're probably saying that once a certain amount of flattening of the curve has been seen in a high prevalence zone, and if the rest of these economic activity can open up gradually and carefully,
Yeah.
and keeping the connectivities more virtual through internet businesses and whatever, it would be safe to gradually return back to economic activities.
Yes, yes, yes.
Okay, okay. Any other question? Because I don't want to hold up too many questions here. Okay, there is one gentleman, Dr. Konthu Jam. Am I saying it correctly? He says, can you suggest about the economic integrity and medical infrastructure after the long lockdown?
Yeah. Uh,
Medical infrastructure,
Medical infrastructure.
in the sense of the hospitals and tele consultations instead of people going back and forth, because lockdown is still a raw situation in terms of COVID presence in the hospitals. So
Yeah.
for some time, people will have to still feel that if you can avoid going to the hospital for some more weeks,
Yeah.
and go in for teleconsultations, which are now legal in India and many countries,
Yeah.
including the US. Most of the uh, non-emergency cases in the US
Yeah.
are now being handled through teleconsultation,
Yeah.
and not necessarily that they should have been examined physically by a physician or a surgeon.
Yeah.
Yeah, Jeff, back
Yeah,
to you.
I yeah I believe that if the value chain of medical consultation engagement is broken amongst different players, uh, I'll just elaborate what I'm saying, and then a sort of uh, a digital vault is prepared where an examination can be put. It's possible. So I'll elaborate on this statement which I made. So, for example, if you were to go to a doctor for a supposed complaint of a thyroid, yeah. Now, typically, you go across to the doctor. The doctor asks you some questions. Sometimes, like have you had iodine in the last few weeks? Have you applied some anti-inflammant? And there's a series of Q&A, and then there is a medical test of the blood, which lists, okay, here are the possible indicators, and then there's a review of the report, and the doctor prescribes a medicine. Now, in what has happened in the age of lockdown is that a lot of services today are available to home. So in case a condominium or a society, a group of houses could just have a secure space wherein collection of pathological samples were to take place. Yeah, a pathological agency comes from outside, collects samples, and goes away. Now, if you combine that with telemedicine, and all the results are stored in a digital vault, like a Google Drive, for example. I mean, just giving a very simple example, Google Drive is also a digital vault. The government can have secured digital vaults because this is medical information, and the doctor's observations, the observation of the path lab can be all put in the digital vault, and the doctor can actually give a prognosis after looking at it and prescribe medicine almost like a tele face-to-face consultation. If we're going to implement that, I think even without a lockdown, that's a very good solution to have.
Great. I think these are discussions that probably can keep on going back and forth.
Yeah.
That's another question from Dr. Swati Maheshwari. She's asking which would be the parameters. I think this is a question for Dr. Zhou. Which parameters do you see as early flag signs for COVID infection in any virgin area? There are like 300 plus districts in India out of the 700 districts, and there are no COVID cases yet in these 300 plus districts. And I think this is the question I'm sorry, am I audible? Okay, was I
Yes, yes,
audible for this question?
yes, sir. You were audible.
Okay. So the question that Dr. Swati Maheshwari was asking, has asked is, what would be the early signs of COVID cases in those 300 districts of India which do not have any cases of COVID as yet? No cases diagnosed as yet. So Dr. Zhou, do you want to give us a little feel of that?
Okay, actually, this is a little bit difficult for us because I never been in the community level in India. I only in the city, New Delhi. So maybe it's not real suggestion, but for our Chinese experiences, we set up the special fiber clinic. We call the fever clinic.
Fever.
All the fever patients needed to go to specific clinic in the front of the hospital for the screening and the epidemiology history investigation. Then the medical doctor can identify is this suspect cases or not. So this fever clinic really can help to screening, or we can cause a passive screening, passive surveillance for those fever cases.
Yes.
So this really can help for the community level.
Sure.
And
Just to add, Dr. Zhao, is that fever clinics, a fever is one of the early symptoms in certain areas. At the same time, loss of smell sensation, or what has now come as the US CDC recommendation of 6 other symptoms and signs, such as shivering, for example. And these people again can go back to the fever clinics in the hospitals and in the city councils. Yeah, great.
Yeah.
Okay. Any other questions? I have a question for Jay.
So we have a couple of questions.
Okay, come along.
Yes, Sudhanshu asks, what are the different kinds of community engagement measures that we can take? If the speakers could speak a little bit more about how the community could be involved.
Yes, maybe my colleague Dr. Xiao, he will give the response to the community involvement. Dr. Xiao, please. Xiao-Ning, please.
我没声音不太好。
Community activity. What kind of community activities during against the COVID-19?
Yes, thank you for your questions. That's a very, very key in Wuhan and in China. So the communities, community organizers, or the community, all the citizens, if they are participating in these activities, should be very important. As you know, so it's first is the community is divided many small areas. So in these small areas, we call it looks like the village. A lot of citizens live inside. So first is door. Door is the keeping. So any person enters must give the temperature monitoring. And the organizer of the community, we call is kind of the institution, or the how to say, is also officials. They organize the volunteers to every day to visit house by house to know any status, have any fever cases in the family members, or if they find some of the fever cases, first send them to the clinic to get the examinations.
Yes, that's all.
We have one question for Mr. Mrug. While in India, the death rate versus recovery curve is widening, have we surpassed the peak of the pandemic? This is a question from Tanushka Ojha.
Okay. My sense is that we are not yet at the peak of the pandemic. We're about.
Sorry, the connection is the blocked.
Okay.
Let's see.
Are you able to
So
hear?
yeah, I just connect again.
Okay.
Can you hear me?
Yes.
Yes, yes, we can hear you.
So this is volunteer is very key to identify any suspected and send them and send them to the clinic to get to the detection. So it's a key. That's what I experienced. Thank you.
Okay, any other question, Secretariat?
Yes, I think we'll just ask Mr. Mruk to respond to the last question regarding the death rate versus recovery rate, if he'd like to add something.
Yeah. Now the funnel is widening in India, which means we are on a healthy recovery for the patients that are already infected. Have we surpassed the peak of the pandemic? I think we are currently in the peak. I mean, I would be very keen to observe what happens for the next 2 weeks. Yesterday, we've added almost a little shy of 4,000 cases, which is a peak. We've never added that daily amount anytime before. I think we're entering the peak. Normally, my observation with all data is that somewhere between the 6th and the 8th week, you tend to hit a peak. So I think the next 2 weeks are crucial. And then we would perhaps say that we are passing off the peak.
Great, excellent. One last question I will ask Jai, and that is about social infrastructure that he talked about. Now, it's a COVID epidemic or COVID pandemic that has stimulated so many issues about socioeconomic and, of course, the medical and mortalities and things. But the social infrastructure thing that you showed, especially for large economically active cities and countries, you're looking for what kind of options available for people, for institutions, and for governments in terms of providing more decent social space for families.
Yes.
It may not only be for COVID, because COVID is just there and probably we won't see it after many, many months, but there could be some others in future. And in that case, now your answer.
Yeah, I'm very glad you brought up this point, and I think COVID is an incidental occurrence which has provided us with a very good opportunity. A lot of the economics, of economic revival, the theories and policies, depend on a state stimulus. They say that, okay, the state can spend more on roads, the state can spend more on infrastructure, and that also, revs up, it brings the economy out of the stagnation. I think housing, and especially lower income group housing, now provides an opportunity for an economic stimulus. So if funds are allocated to that, not only are we looking at sectors like cement, steel, even a lot of unorganized labor is likely to get employed. It's also going to serve a long-term cause of having a more sanitized nation. So I think a low-income group housing should be viewed that way, as an economic opportunity that COVID has finally brought out serendipitously, not quite out of intention.
Great. I think we have really run out of time. So it's time now to put a few closing remarks quickly. Thanks, of course, to both the speakers, our colleagues who have really shared information and made it much more impactful for us now to move on to the third webinar that will be held next week, same time on 12th May, and that will be on diagnostic and testing. So obviously much more debate and much more questioning on that. The Global COVID Network will bring more distinguished speakers for that, both national and international. Let me thank the Secretariat, my colleagues, basically Kamila and Anubrata of Sambodhi, who have been so helpful and managing this so well. So kudos to the Secretariat, and I think I will then close the webinar number 2 at this point. Thank you all for to the participants. There are some few questions which I have not been able to, towards the end, be able to address, but we will keep discussing them as we go along. So from all of us, it's goodbye.
Thank you. Thank you.
Thank you.
Thank you, Chair.
Thank you.
Bye
Thank you,
bye.
Dr. Xiao.
Yeah, bye bye.
Dr. Zhou.
Thank you, Dr.
Bye-bye.
Zhou.
Bye. Thank you. Thank you. It's a pleasure.
Thank you all.
Bye-bye.
Thank you all.